Because you don't ask.
Okay.
We have a lot of students, and we teach the first year students, second year here in our language. And today they have an exam, and I'm sure now they are in the exam and just
Oh,
give
I
me the
see.
answer,
I
and
see.
such like that.
Okay.
Sorry.
So we do a combination therapy. So we give the LH-RH analogs and the androgens in the same time. These are the new ones, the antagonists. The new drug is called Firmagon, Degarelix. It's more effective because the antagonists decrease the testosterone level immediately. See, in 24 hours. No need for anti-androgen, right? Because no flare. What is flare? Flare up is a sign when you give
You're hot.
Hot. You're gonna sweat, and the cheek will be reddish, right?
Excuse me, when they stop the release of the testosterone, what happened? The hair lost, the feature like a woman.
Yes.
The
So,
voice change. This is not good for the patient.
If you will, in the past we had patients treating the patients with hormonal therapy for years. So these patients, old males, of course, these patients had different kind of side effects. Many of them, none of them had normal erectile function, right? That's the very first. So all of them have erectile dysfunction, right? Secondly, obesity. Most of them increased in weight. The other one is the gynecomastia. You know what it is?
Yeah.
The painful enlargement of the mammal gland. Almost all of them had gynecomastia, right? The voice, the sound of the voice become more higher than in normal.
Higher? What do you mean?
Like in females. Obesity, erectile dysfunction, the voice, gynecomastia. Basically, these are the most frequent side effects.
Why do they don't remove the prostate gland? This is more
Because,
easier and more...
Well, wait. So now we are talking about locally advanced or metastatic diseases. So let's say in a case of a metastatic disease, when the patient has bone metastasis or lymphoglandular metastasis, there's no need to remove the prostate. It's almost it is because it's already has metastasis. The situation in the around the prostate is very hard. So you are unable to take the prostate itself out without hurting or damaging vessels, neural fibers, and so on and so on. So it's unfortunately the locally advanced and the metastatic disease is far away from the surgical option. It's not an option. Unfortunately, it's not an option. Okay. Finasteride and bicalutamide as a combined treatment. It depends. Nowadays we don't use this kind of combination because the Firmagon, the Degarelix, the LH-RH antagonist is very good and very effective, and the LH-RH analogs are more effective than these combinations. So results, right? Impotence, erectile dysfunction, loss of sexual desire, loss of libido, of course, hot flashes, weight gain, as I mentioned, reduced brain, well, no, it's not, loss of muscle and bone mass, and, well, cardiovascular risk, of course, the risico of having a myocardic infarct, let's say, or ischemic episode is of course is higher than in a non-treated patient. This is a very special situation, hormone refractory prostate cancer. When you give the hormone and somehow the disease just growing and growing and growing. The answer is that if you take a population of prostate cancer cells, the cells, the cancer cells have their own genetic defection, right? And basically the cancer cells can learn how to be resistant to the hormonal manipulation, right? And the receptors no longer are available to block the growth, the proliferation of the cells. So those cancer groups or cells are become a hormone refractory prostate cancer cells, and they can proliferate very, very fast. And what you see is the PSA level is increasing. So you have to do something else. You have to change the therapeutic option, right? The therapeutic option is cytotoxic chemotherapy, docetaxel, and prednisone, well, or mitoxantrone. So these are chemotherapeutic agents. Probably you have heard already.
Yes, today we have.
When the patient needs chemotherapy, then the oncologist come and they give the chemotherapy agents, not the urologist, right? So in this situation, well, we let the patient treat by the oncologist. Okay, bisphosphonates, well, decreases the skeletal complications. Just a minute. So the metastatic disease, hormone therapy, of course, or chemotherapy if the cells become hormone refractory. Bisphosphonate against the metastatic bone disease. Supportive care. What does it mean? What does supportive care is? Pain release, right? Do something against their pain, because the bone metastases are really, really painful, right? Okay. Energetic treatment. No, I don't. I won't. I don't like it. I have no idea who it is, anyway. Let's check. Damásny Miklós.
Your wife.
Mondja csak. Na. Igen. Az jó. Na most közben itt volt egy ilyen belső onkotém a Kornél ügyével kapcsán, és az volt itt a vélemény, hogy lehet, hogy jobban járna Kornél egy műtéttel. A műtét egy úgynevezett retroperitoniális nimf adenektómia lenne, amikor eltávolítanánk azokat a nyirokcsomókat, amik feltételezetten daganatdsejteket tartalmaznak. Ugye az a gond, hogy hogyha emlékeznek, én ráírtam, hogy a 40% így van, az a bizonyos éretlen teratóma. Na most a kemoterápia az éretlen teratómát azt ugyan hat rá, de a sebészeti eltávolítás sokkal effektívebbé tenné a hatást. Tehát valószínűleg jobb lenne nála egy ilyen nagy hasi műtétet elvégezni, és a nyirokcsomók feldolgozása után, ami patológiai véleményt adna, utána, hogyha az pozitív, megkapná a kemoterápiát. Igen, most így van, igen, ezt beszélgetünk, hogy valószínűleg jobb lenne, és nem is mert a szeminóma az a kemoterápiát jelenteni, de az éretlen teratóma az nagyon veszélyes. Tehát az úgynevezett kemorezisztens állapotot is előtt, tehát a kemoterápiás készítményekkel egy idő. Ez az. Viszont sebészileg, ha el van távolítva a régióból a nyirokcsomó, akkor nincs hova menjen a daganatsej. Tehát ez a nagy előny. Igen, tehát ez most egy ideális állapot lenne. Úgyhogy most ez volt itt, mert ugye meghánytuk, vetettük a Kornél ügyét, és hát ez volt a felvetés, hogy jó lenne ezt. Ez úgy menne, hogy én begyűjtöm az információt, mármint a CT leleteket, és akkor nálunk, aki kollega ezzel foglalkozik, oda viszem elé az anyagot, és akkor megbeszéljük egy időpontot, amikor lejönnek, és akkor a műtét előnyeit, hátrányait szintén át lehetne beszélni. Természetesen ez egy nagyon komoly hasi műtét. Az egész hasüreget meg kell mobilizálni, a nagy hasi erek mellett lévő nyirokcsomókat kell kivenni. Ez komoly technikai fel. Ezt mi ez? Abszolút urológus sebész végzi. Persze. Hát én csak asszisztensként, tehát ez jóval nagyobb tapasztalat kell, mint nekem van ebben a régióban, de van egy kollégám, a pusztai főorvos, aki évek óta, sőt évtizedek óta ezt műveli. Tehát ő az, aki ezeket a műtéteket elvégzi, és neki nagyon szívesen én ott leszek, asszisztálok, de az ő kezébe kell adni ezt a beavatkozást. Akkor nagyon jó, akkor akkor nem kell utókezelni, igen. Úgy van, varratszedése. Hozzá kell a leletet. Jó van. Oké, a markerek azok negatívek lettek, amiket levettünk. Hát azt is vártam, nagyon szívesen. De jó volt. Oké, csak. Sorry. It's over. So, bone involvement treatment, bisphosphonate.
I have a question. If somebody wants to donate bone here in Pech, where should he go?
Hematology.
Where?
The 400 Beds Institute. The 400 ágyas. Hematology.
They are linked to the worldwide bank of the donor bone marrow. That if somebody is matched, they can use it.
So all the diagnostic procedures and everything are done by the hematologist here in Hungary.
Dr. Kozegi, yeah? Or no? I think we should speak with Dr. Kozegi.
Kőszegi? No.
Laboratory.
He is a laboratory medicine physician. No. Dr. Somor.
Dr. Somor.
Árpád Somor.
Yeah.
Dr. Ágnes Nagy. And who's the third one? Dr. Somor is the head of the hematology clinic now, I think.
Okay. Because one of my friends needs a
Bone marrow.
transplantation, and she's in Canada. She asked everybody on Facebook, please. Maybe one of you is matched with me.
Good.
I want to go there. Maybe.
So you should go there.
Is it very painful?
It is. Because you have to, the bone marrow, here's the pelvic bone, here very close to the skin. So here, or from the sternum, a sample should be taken. bone marrow sample, right? Otherwise, matching are not gonna be able to solved.
You should break the bone.
Or they doesn't take just the one swim on the mouse.
I have no idea. So no, I've never done it. I have no idea.
I just last night I go to the website and I found just one website in Europe, is in Austria and in Poland, and they are linked to the World Bank of the bone marrow donor.
Mm-hmm. I have no idea, so I cannot give you suggestions, recommendations. I have no idea. Some kind of diagnostic procedure should be done. I know. The types, who knows? Hematologist.
I go to YouTube. It's written. This is not painful. No surgery. Just they give you one cotton. You should put it on the mouse and give it. And if your tissue something like it was matched, in this case you can help it. But I think
possible.
This is more scientific that transplantation taken.
Yeah. Okay, the last slide. We're gonna finish it. So, BISPHA hormone reflector. Okay, so biochemical or with imaging detected protection chemotherapy, the docetaxel, which is the estromustin phosphate and mitoxantron, right? So that's all, folk. So, summarizing the 2 days.
Important question.
Important take-home messages, right? So BPH is one of the most important issue in urology, right? There are many different kinds of conservative treatment options. Alpha blockers, enzyme blockers, the combination of the two, phytotherapeutic agents, and what you have to know about your patient is the stage, the disease stage, because there are 4 different stages in BPH. Stage 1, the symptoms, very few symptoms are available, mild symptoms. The 2 or 3 are the main conservative treatment options. The 4th stage is probably equal to the acute urinary or urinary retention. The patient cannot empty his urinary bladder, right? So surgery is probably the 4th. The stage 2 or 3 are the main 2 the conservative treatment options. So that's BPH, right? The prostate cancer is another important issue in urology. You have to prove the malignancy. The provement means you have to take a transrectal needle biopsy, right? And if the needle biopsies are positive, then you have to do the staging. What does this mean? Staging means that you have to ask CTs, computer tomographies, right? Thorax, abdomen, and the pelvis, looking for lymph nodes metastasis or parenchymal organ metastasis and the bone metastasis, right? And if the disease is local disease, then the options radical prostatectomy, which is a surgical, or irradiation or brachytherapy. But if the disease is locally advanced or metastatic, then you have to do something else. Neoadjuvant hormonal therapy, or the disease is metastatic, then bisphosphonate to eradicate the pain of the patient, right? Lithiasis, urolithiasis, is very common here in Hungary and probably in your country as well. Well, the main therapy of the stones are surgery, right? You have to take the stones out. That's the main issue. But there are certain type of stones uric acid stone and the cystine stones, you can dissolve, right? Uric acid stones, you have to do a
Alkalization.
Well, alkalization, right?
And inhibit xanthine oxidase.
Right.
Allopurinol.
Yeah, allopurinol.
Milturic.
Milodit, yeah.
Milturic.
In cystine stones are options.
We should dissolve it again by
D-penicillinamide
penicillin for the
Or-
Wilson disease.
or a special
Kelater.
thiazide, hypothiazide. It's a very, very special diuretical agent.
Chlorothiazide.
Yeah. The other ones, all the oxalate or the struvite and so on, and you cannot dissolve. Impossible. What you can do is giving antibiotic against certain kind of gram-negative bacteria. But the rest of the stones are or should be removed by surgery, right? Continency. It's a very confusing part of the urology because the diagnostic procedures are really long. So you have to be sure that your patient has a stress on an urge or a mixed or a overflow incontinence, right? The urge incontinence has a special conservative therapy. What kind of receptors located on the surface of the detrusor muscle? Muscarine, right?
Yes, M2.
And there are the other receptors located to the bladder neck and the trigonal part. Those are called alpha 1B, alpha 1B receptors. So if you give anti-muscarine agents, what?
Why D is dopaminergic?
I have no idea.
Alpha
1D.
Oh, you mean alpha 1 of sympathetic and a special type of alpha 1 is
Yeah.
indeed.
It's a subtype, alpha 1, subtype 1D. So if you give anti-muscarinic agents, you're gonna block the muscarinic receptor. What happens?
Just the upper part is constant.
Well. If you the anti-muscarinic agents will decrease the autonomic
The desert
movement of
muscle
the-
relax.
It relaxes the detrusor muscle. If you give muscarinic agents,
The desert muscle contract.
contractility. Yeah. The alpha blockers will relaxes the neck of the bladder, the trigonal part of the bladder, and the posterior part of the male urethra. Right. There are other options. Relaxing the detrusor muscle, botulinum toxin, let's say, but it should be given locally, right? Or capsaicin, right? Locally, not per oral, only locally, right? Good. Okay.
Just this, you want to ask it on the exam, nothing else. Please think a little bit more. Maybe you want to ask other different questions.
Well, I have to ask
5
about the administration because I have no idea. I've never heard of giving test questions. Well,
it means you don't ask you the question?
I wasn't. Well, I haven't been asked.
But this is first time English program in 5th year.
Oh, really?
my God.
Maybe
You are the first one.
Yeah.
You should make a question and send it to Istvan.
Istvan.
Sitter.
You know Istvan Sitter?
Pharmacology department. Erika Pinter.
Istvan. What's the first name?
Istvan.
Oh, the surname.
Sitter.
Sitter.
Yeah. He's a resident in pharmacology
right?
He's a very good guy and he's responsible for us.
Okay, so I'm gonna ask him. Okay, right. I'm gonna follow. Okay, good. I'm gonna. Good.
But all of the teacher write this question to Sita.
Good. Okay.
Thank you so much. Oh, yeah.
May I take this off?